Hello, and welcome to another lecture. Today we're going to go over this heart segments for wall motion evaluation, and I think is a very important topic that all of those who are practicing in the area of echocardio, you're going to love this. It's going to give you a lot of information, especially if you're doing a stress test in your office. This is going to be perfect for your knowledge. So let's get this done. Let's start talking about a little bit of the anatomy of the coronary arteries, so we can know the distribution of the flow, and if we know where the coronary arteries are going, so we can tell, hey, if the left anterior descending, for example, is has a plaque and it's not sending enough flow to the segments, we can say, hey, look, the anterior and segments and the septal segments are affected. If, for example, the circumflex is the one that is affected, we can say, hey, look, the lateral segments are the ones that are affected. And if, for example, the right coronary artery is the one that is affected, then we can say, hey, look, the inferior segments are the ones that are affected. So that's the point of why we're going to go over the anatomy first. Okay, moving forward, let's take a look to this picture here. Look for laser pointer here. All right, so look at this. All right, so this one is the anterior or sternocostal surface of the heart, and here is the right atrium, here is the right ventricle, this is the left ventricle, and we have this sulcus here that we call the, look at the name, it's so easy to remember if we take in consideration the anatomy. So it's going in between the atrium and the ventricle, so we call this one the anterior atrioventricular sulcus, this one right here, or it has another name, we call it the coronary sulcus, and we're going to have the right coronary artery going through right here. And this other sulcus here is between the right ventricle and the left one, so we're going to call this one the anterior interventricular sulcus. And then we have this important artery running through that we call the left anterior descending, and it's a branch of the left coronary artery. All right, so that's for the anterior surface of the heart. If we move to the posterior one, so we have right here what we call the posterior atrioventricular groove. We have the coronary sinus running through, but also we have the circumflex, which is a branch of the left coronary artery. And we have this one right here, look at the name, we call this one the posterior interventricular sulcus, and then we have the posterior descending artery, which is basically a branch of the right coronary. So if we know this, if we understand the distribution of the coronary vessels, this is going to be a piece of cake for later. Because I know the segments are a little bit complicated. It took me a little while when I was studying this to understand, and to remember, which I think is the most important. All right, so what is the coronary artery disease? It's very common, let me tell you. So we have this plaque, which is the combination of so many things in there, like for example, fibrosis, cholesterol, and of course, what happens is that, this vessel is just going to block over time. The muscle is just going to start having ischemia, right? Which is the lack of nutrients and oxygen, and the patient is going to present with different signs and symptoms related to this problem here. This is what's going on in here. So we have, the process of plaque formation is complex. It's even more than this. But you know that there are like different risk factors that are going to lead the patient to have this coronary artery disease. Okay, moving forward, risk factors, I was saying before, we have the diabetes, the hyperlipidemia, smoking, the gender. Let me tell you something, cardiovascular disease is more common in men, and it tends to be more common in women after the menopause, all right? And then the age, as we're getting older, so we're having all these problems, and I think age is a risk factor for any type of disease, right? Or at least for many diseases. Okay, so let me repeat this one more time. We have a diabetes, we have the hyperlipidemia, we have the smoking, the gender, and the age. All right, let's moving forward here in the physical signs. Let's talk about this angina here. All right, that could be stable or unstable, and the presence of a new murmur. That could be because the mitral regurg, so mitral insufficiency, or ventricular septal defects that are going to form, basically because the area that has been affected by the heart attack or the infarction that happened. So when I say mitral regurg, the causes could be like, for example, rupture of the chordae tendineae, rupture of a papillary muscle, right, for example. And let's talk a little bit about this angina here. Okay, the angina, as I said before, it could be stable. And stable means that this pain or discomfort that the patient is going to present, which I think, and I can say is more like a sensation of oppression in the chest. All right, that's what the patient is going to complain about. And this stable, it usually happens when the patient is doing any type of activity where the heart requires more oxygen, right? And the patient can tell when this is going to happen. Like they say, hey, every time I walk or every time I jump or I do any type of activity, I start feeling this, sensation of oppression on my chest. And as I said before, it's predictable. So the patient can tell when this is going to happen. In the other hand, unstable angina, it just happens. So the patient cannot tell when this is going to take place. And patient may be sitting in the chair, watching the TV, having a great time, and then this discomfort, this pain is just going to show up. And so this one, sometimes it doesn't resolve with the medication, all right? The nitroglycerin that the patient is taking, so maybe the patient has to go to the hospital. So this is worse than compared to the stable one. All right, stable one is predictable. The unstable, no, it doesn't go that way. All right, so you know what angina is. So let's moving forward to the next presentation here. So now complications of ischemia or ischemic disease. We have arrhythmias, death, aneurysm, pseudoaneurysm, which is a false aneurysm, pericardial effusion, and this pericardial effusion after heart myocardial infarction, we call this Dressler Syndrome. We have thrombus, right? Papillary muscle dysfunction, papillary muscle rupture, that this can lead to mitral insufficiency, and ventricular septal defect, because this can cause, right? Because remember, we have ventricular septal defects that are related to congenital problems, right? But this one is because in plain words, the interventricular septum is just going to break. Boom, it happens. So let's take a look at this picture here, right? This little clip in here. This little clip shows this apical lung axis view. It's one apical lung axis, and here we have the mitral, here we have the aorta, right? The aortic valve in here, left ventricle on this picture, and look at the apex here, right? So this is what we call one aneurysm, and this area right here is kind of hypokinetic. It's not moving well. Maybe the segments here are affected, but the thing is, like, there's a dilation with a wide base in here. Now, if we take a look to one pseudoaneurysm, look at this one here, pseudoaneurysm is a false one. If you take a look, the base is like narrow, is more like a neck, and here we don't have, it's not made of muscle, it's going to be made of pericardium. So compared to this other one here, this is made of muscle, all right? So therefore, this pseudoaneurysm is going to have more chances for what? For rupture. So this is considered one medical emergency. Just in case you're scanning and you find that something like this, you have to let your doctor right away that you found this, and of course, you know, this patient needs a further treatment. So look one more time. Here we have the aneurysm, and here we have the pseudoaneurysm. So moving forward, look at this. I have this nice comparison between the true aneurysm and the pseudoaneurysm. Look at this one. The true aneurysm, the base is wide, as I said before. In the pseudoaneurysm, the base is narrow. In the true one, so we have the walls made of myocardium. In the pseudo one, the walls are composed of thrombus and pericardium, so that's why we have a high risk of rupture here. And for the true one, we have a low risk of rupture, so that makes the pseudoaneurysm one medical emergency, so that's good to know. All right, look at this one. This is another complication. So here in this wall, we have one thrombus right there. All right. So it's hard to sometimes differentiate thrombosis. So that's why contrast bubbles, they help. All right. So they help, but thrombosis could be another complication of this. All right, could be another complication. So and you have to be very careful when you're looking for thrombosis, because if you take a look to this video, it may give you the impression that maybe what the patient has is hypertrophic, you know, wall in there, but it was determined later that this was a thrombus in this area, in this segments in here. All right, so let's move forward here. And this is a TEE view. That's the here we have the mitral, all right, in this TEE view. And as you can see it, I want you to take a look at this video. Look at here, see what's going on. There is a papillary muscle rupture, and of course this is going to give you a flail leaflet. And if you put the color flow here on this picture, so you're going to have maybe a huge regurg or insufficiency taking place in here. So you're going to see that jet of mitral regurg or insufficiency taking place. So that's another complication of ischemic disease. All right, let's move forward. And well, look at this, mitral insufficiency and left ventricular dilation. Yes, that's another complication. Look at this here. So this ventricle is that's a simple view. You can see it's dilated. Yes, it is. And also this left atrium is dilated. And look at the mitral insufficiency in here. All right. So remember, there are different ways to know how bad this mitral insufficiency is. Like you can use the PISA method, and also you can compare the area of the mitral jet to the area of the left atrium. You can use the vena contracta. There are different methods. Also, you can use the DPDT to know how well is the ventricular systolic function preserved. So, but definitely if you take a look to this little clip in here, you can notice that the left ventricle is dilated and the left atrium is dilated too. The contractility is affected, especially where in the area of the interventricular septum. Okay, we're going to call the segments in here, so infraseptal, all right, infraseptal. All right, so let's move forward and look at this. We have a swinging heart in here with right ventricular wall collapse in here, and there's a lot of fluid around. That's a huge pericardial effusion. We may say cardiac tamponade, all right? And this happened after what? After one myocardial infarction, and then we call this the Dressler Syndrome. All right, so I hope you are understanding and having fun with all of this. You always have the option to go back in the video and take a look to all these clips in here. So that's the, here I have a picture for a ventricular septal defect in the, muscular area. Remember something, the congenital ventricular septal defects are more common in the membranous part of this interventricular septum. But here this is in the muscle area, all right? And if we use the color flows, and we can see, you know, the color going from the left ventricle to the right one, okay? Okay, well, motion classification, we can use the term hyperkinesis. That means that segment is just moving more than normal. Hypokinesis, that means it's moving less than normal. Dyskinesis means a snake motion or motion in opposite direction, something like this. It's like more disorganized. I think it's a little bit easier to notice if you have good eyes, right? And you've been practicing this for a long time. And the other term is akinesis, which basically is no motion, no thickening, all right? So it's like frozen right in there, so the segment or the segments are not moving at all. Okay, so as I said before, remember, as a general rule, for the anterior and septal segments, the left anterior descendant is the artery that is going to perfuse, it's going to send flow to that area. For the inferior, we're going to say the right coronary artery. And for the lateral wall, so we're going to use the circumflex. So don't forget about this. This is really important. So anterior and septal, we're going to have the left anterior descendant. Inferior, so we're going to have the right coronary artery, and then lateral, so we're going to have the circumflex. Now, let's take a look at this one. And let me get some water, because this one it will take a little bit more of time to understand. All right, so right here, we have the different views that we do in the normal protocol. Like we have the short axis in here. This is the apical, this is the mid at the level of the papillary muscles. Then we move to the base close to the mitral. And then, of course, this is a 4-chamber, 2-chamber, and what we call the 3-chamber or apical long axis view. I'm going to help you here to understand a little bit better. So we're going to use 16 segments plus one extra segment, 17, which is going to be this one up here that we call, this is segment number 17. We call this one the apical cap, CAP, all right? Apical cap, the segment number 17. So let me go here. I'm going to use a pen. So this is the way I think for my students, they able to understand this a little bit better, because I know it's confusing and hard to remember. But I always do the following. I say, hey, let's use numbers first. We're going to begin at the level of the base, right here. Those are short axis views. And we're going to say this is segment number 1. This is segment number 2. This is 3. This is 4, 5, and 6. And if you notice the pattern, I'm just going counterclockwise, all right? Therefore, this one right here has to be 7, this one 8, 9, 10, 11, and 12, right? And this one is 13, 14, 15, and 16. So we have the 16 segments in here. Now we have to place those numbers up here depending on the names. But look at the names here. So we're going to use names and last names, all right? So because we're here at the apex, this is the apex, all right? We're going to call this segment right here, so apical anterior. And we're going to call this one here apical inferior. And of course this is the septum, so we're going to call this one apical septal. And this is lateral, so we're going to call this one apical lateral. So if you know this anterior, inferior, septal, and lateral, then you're not going to have any problem to understand mid and base. Because this one is going to be mid anterior, number 7, mid inferior, number 10. Now, if you take a look at the septal wall, now has 2 segments instead of 1 like in here. But this segment is close to the anterior segment, so we're going to call this one anteroseptal or anterior septal. Anterior, why? Because it's close to the anterior segment. Septal, because what? Is in the septal area, right? So number 9, because it's close to the inferior segment, we're going to call it infraroseptal, mid infraroseptal. So just apply the common sense right now. This one, number 12 and number 11, both belong to the what? To the lateral wall. So we're going to call this one, because it's close to the anterior, all right, anterior segment, we're going to call this one anterolateral, all right, and this one right here, we're going to call it what? Inferolateral, because it's close to the inferior segment. Remember, use name and last name. For mid, remember, mid is the name, mid anterior, mid inferior, mid anteroseptal, mid infraseptal. Mid, this one right here will be what? Anterolateral. This one mid for number 11, so we're going to use infralateral. How about here the base? All right, base is going to be the same thing. All right. So basal anterior, basal inferior for number 4. For number 2 and 3, look at this: basal anteroseptal, basal infraseptal. And then for number 6 and 5, basal anterolateral, basal infralateral for number 5. So that seems to be a piece of cake. Yes, it is. Look at this here. Now, what I think you have to apply more ear memory and remember more data will be when you go to the names for this walls in here. So this wall here, this one right here, okay, this one right here. So we're going to call it the infraseptal. And this one right here, we're going to call it the anterolateral. All right, this wall here, we're going to call it inferior. This one right here is the anterior. And notice something, the 2 chamber is the only one that has like pure walls, inferior and anterior, so it doesn't have a combination of segments. Like, for example, the 4 chamber, as you saw it before, and the long axis. Look at the long axis. So this one right here, we're going to call it, all right, infralateral, and this one right here, we're going to call it anteroseptal. Now, let's take a look to this one more time. So here is the base, all right, so the segments in here, the segments in here, and the segments in here. You're going to find those were right here, because that's the base. This one is mid. This one is mid. This one is mid. So all the segments in here are going to be found were right here. And this is apex, apical, apical, apical. So segments in here are going to be found were right here. Okay, base, mid, and apex. So let me use numbers so you will understand this. All right, let's say this one is base from the infraseptal wall. So we're going to call this one what? Basal infraseptal. Basal infraseptal. So it has to be which number? Let's go here. Basal, all right. Infraseptal has to be number 3. So this one here, we're going to call it what? Mid infraseptal. Has to be number, right here, okay, number 9. And this one right here, we're going to call it apical septal, all right, because we don't have combination of segments in the apex. Has to be either anterior, inferior, all right, septal, or lateral. So because it's septal, this one is going to be number 14. So this one is basal what? Basal anterolateral. So this one has to be number 6. And this one has to be mid anterolateral. All right? And that will be what? Number 12. And we go to the apex. We don't have combination of segments in here. So we're going to say, hey, look, this one is apical what? Apical lateral. Which is going to be... apical lateral will be 16 here. All right. And remember, this one up here will be number 17. Now we'll go here. This one will be basal inferior, which is going to be number 4. All right. So this one here will be mid inferior, which is going to be what? Here. Number 10. And this one right here will be apical, what? Apical inferior, which is going to be number 15. So how about this one here? It has to be basal anterior. We'll go here. That will be number 1. This one will be mid anterior, which is going to be number 7. And this one has to be what? Apical anterior, which is number 13 in here. All right. So how about this one? How about this one here? Okay, look at this. This is inferolateral. So this one has to be basal inferolateral, all right, which is going to be, boom, basal inferolateral is number 5. And this one has to be what? Mid inferolateral, all right? We'll go here, mid inferolateral. That has to be number 11, right? And this one is going to be apical lateral, because the apical inferior, you have it in here. So this is apical lateral. So this one is number 16 in here. Alrighty, so here, this one has to be basal anteroseptal, which is number 2. This one right here has to be mid anteroseptal, which is going to be number 8. And this one, we don't have a septum anymore. Septum is done, all right, because this is the right ventricle. So we're going to call this one apical anterior. So we have number 13. All right, so let me give you a little trick in here to remember. Look at this. 3, if you know that here we have a number 3, so we go 3 plus 3 is 6, all right? Then here 1 plus 3 is 4. And here 2 plus 3 is 5. So you're going to have a difference of 3 in the basal segments. So 3 plus 3 is 6. 1 plus 3 is 4. 2 plus 3 is going to be 5. Now, between the basal and the mid segments, we have a difference of 6. 3 plus 6 is 9. 6 plus 6 is 12. 4 plus 6 is 10. 1 plus 6 is 7, 5 plus 6 is 11, 2 plus 6 is 8. And then, of course, you need to work with the apical segments, all right? With the apical segments. Remember, we don't have a combination of walls, so we cannot use the terms like anteroseptal or inferolateral or inferoseptal or anterolateral. So it has to be anterior, inferior, septal or lateral. So those are the terms that we're going to use for the septum. So I hope you get this. Also, you have all these colors in here for the distribution of the coronary arteries. Okay, this is gonna help you. But remember something, as I said before, for the inferior segments, the right coronary artery. For the lateral, the circumflex. For the septal segments, we're going to use the left anterior descending, as well for the anterior segments. All right. So let's take a look to this view for one ultrasound. This is one short axis, and sometimes when you give this picture to students, they think this one is the anterior segment because you study those pictures this way here. Let me tell you something. The heart doesn't have the same position in all patients, so that's good to know. The axis can rotate. Well, my advice is that go here and find where the right ventricle is, right here. And then, of course, if this is the right ventricle, so this one here is what the interventricular septum. So therefore, all here is the septal segments. Here we have the lateral ones, and of course this one is anterior and this one is inferior here. So therefore, look at this picture: anterior, inferior, anteroseptal, inferoseptal, anterolateral, and inferolateral. And remember, this six segments, they work for the midsection and the base of the heart. Let me tell you something. When myocardial infarction takes place, the basal segments, they tend to preserve more than the mid and the apical segments. So that's good to know as well. All right, so thank you for you know, taking your time to watch this. Remember something every day. Do something that will inch you closer to a better tomorrow. It was my pleasure as always. I ask you please that go to my website right here, and you can leave me a review. So here you have different links. So here you can leave me a review. I have different ones. If you feel like you learn, or you have to say something like if you tell me, hey, you have to improve this, you have to look for better clips or whatever, so you can tell me that one in here, and I will make my best. All right. So also right here, you can go to Udemy right here. Udemy, that's the name, Udemy. All right. And I have a pretty cool course for hemodynamics and Doppler. Right? It's highest rated, it's 4.8 for the rating, so people are liking it. And right now it's on a special, so maybe this changes at the time you see this. All right, but yeah, it's a good one if you want to learn Doppler and hemodynamics, and people are loving it. So they have like very good opinion about this course. They're learning a lot. All right, so here 4.8, and it's hard to have a number 5. All right, it's hard. But yeah, I try my best, but yeah. All right, so also, well, you're watching this on my channel, but if you're not, you can go to my channel here in YouTube, and here I have different videos for, you know, abdomen, MSK, for vascular, for many things. So you can check in here and just leave me a like, and if you want to subscribe, I'm just going to start uploading more and more videos depending on my time, right? And also, you know, have this nice course and my website, all right, which is for vascular. People are loving it as well. This is very complete. So it's going to give you 16 CME credits by the SDMS, and they are recognized by the ARDMS and the CCI. So so I have one annual pass and a monthly pass, all right? So it's, take a look at this one. You're going to love it. Also, I have one for ultrasound physics. So I have a lot of material that you can go over, and it's going to help you to learn and prepare for your certifications or for your registries, all right? And as I said before, thank you for your time, and I'll see you soon, all right? I'll see you soon.